Ramadan Mubarak and good evening for everyone. And thank you all for attending our webinar today, our special webinar that will have during the current circumstances, unfortunately. As the whole world is experiencing this epidemic, hard lessons have been learned in healthcare, as the whole world was in slow and painful shutdown. However, as we all know, COVID cannot stop cancer, and cancer care will continue regardless of what's going on. So that's at SOPA, we thought that it's important to share everyone's opportunity on managing cancer patients during the pandemic. And it was so generous from our panelists and presenter today that they agreed in this short time and during those hard times to be with us today. So prior to starting our session, please make sure that all of you guys ask questions down in the Q&A part of the chat. And we will start our session today with welcoming our speaker, Dr. Mansoor Khan. Dr. Khan is a senior clinical pharmacist of hematology, oncology, and bone marrow transplant at KMAC National Guard Health Affairs and clinical assistant professor at King Abdulaziz University. He will talk to us today about providing pharmaceutical care to cancer patients during the COVID-19 pandemic. He will share some operational and treatment strategies. Dr. Khan, please share with us your screen, and you're welcome to start. Please join me to welcome Dr. Khan.
To everyone, thank you for joining this webinar. And first of all, I would like to say thanks to Dr. Majid Shamrani, Dr. Noura, and all the organizers of SOPA for arranging this much needed webinar. As we know, that we are going through this pandemic crisis where our cancer patients are the most vulnerable patient after the elderly patient population who are the highest for the severe illness in COVID-19. The cancer patients are more vulnerable to contract the severe COVID-19 disease because of their low immunity, their comorbid conditions, advanced age, and so many other factors. So it was much needed to have this kind of webinar where we can agree on certain recommendations to implement it across the country in order to minimize the visits of these cancer patients to hospitals in order to minimize the risk of exposure to COVID-19. So I don't have any conflict of interest related to the contents of my presentation. These are my objectives. We'll describe infection prevention and control during healthcare when a COVID-19 patient is suspected to arrive in the hospital with the guidance from the WHO. We'll briefly touch upon clinical presentation of COVID-19 and risk factors for the severe illness of COVID-19. We'll briefly talk about general principles of managing cancer patients during the COVID-19 pandemic. And actually, I would like to appreciate Dr. Majid Shamrani and other experts of SOPA who came up with beautiful recommendations, practical strategies for managing cancer patients during the COVID-19. We'll discuss these practical strategies in detail, which actually delineate the strategies. How can we minimize the risk, the visits of the cancer patients to oncology center in order to minimize their exposure to COVID-19 in order to mitigate the negative impact of COVID-19. And lastly, would like to make yourself and myself familiar with the CDC guideline and SOPA checklist for pharmacists and pharmacy technicians to protect ourselves in outpatient care setting. First of all, I would like to take your attention on this picture. If you look at this picture, it was taken on 24th of February, which is like 2.5 months ago. And the total number of confirmed COVID-19 cases in the world was 79,000, and most of the cases were actually in China. Almost 78,000 cases were reported in China, and the rest of the world, for example, North America, there were very few cases, 9 cases in Canada, 35 in the United States, and few cases in Europe. And most of the cases were actually in China at that time. So this was a study published in JAMA last week, and they reported how the Chinese were able to overcome this epidemic. It was an epidemic at that time. Later on, it became pandemic. So in the beginning, on the January 1, when actually this COVID-19 started, there was no intervention, there was no lockdown, so this curve started growing up. And by the second week, there was massive migration within the cities, across the border from China to China, without any strong intervention, so the curve started growing up. And then from the third or fourth week, the Chinese government, they started pushing massive lockdown, traffic suspension, and home quarantine. And as a result of that, those strong interventions, you can see there's a steep fall of the curve and all the way down to the March 8th. So we can, you can see like in last 2.5 months, there have been only 4,000 new reported cases of COVID-19 in China. In contrast to the rest of the world, which was we didn't see any cases like 2.5 months ago. It's all orange and red in North America and Europe, and total number of cases approaching almost 4 million, and almost 40 million people have died actually from this devastating disease. As we know that human-to-human spread is the common mode of transmission of COVID-19. So what happens, a COVID-19 patient, when he gets infected, he has the COVID-19 in his respiratory secretion. So whenever he coughs or sneezes or even talks, these COVID-19 is released into the respiratory droplets, and then it's expelled out in the air and stays in the air for some time, for a few minutes. And actually it can travel some distance as well, like 2 meters or 6 feet. So for that reason, CDC gave the recommendation first week of April that all people need to wear the mask where the social distancing is not possible. So that really tells us like how important is infection prevention and control practices, and we need to be familiar with the appropriate infection prevention and control practices, especially when a COVID-19 patient is suspected to arrive in the hospital. We have the guidance from the WHO. So WHO recommends to apply the standard precaution for all the patients, which of course include the hand hygiene, respiratory hygiene, and the use of appropriate PPE according to the risk. But one of the most important things is the early detection, early recognition and segregation of the suspected cases. What happens, so for example, if a patient comes in and we don't know whether the patient is positive or negative, and if this patient is not properly triaged and is not properly isolated according to the risk scoring system. Actually, I'll share with you our risk scoring system for acute respiratory infection. And based on that, we can isolate the patient. If we don't isolate the patient, this patient can spread the infection to other healthcare workers and other family members and other patients. So the key to the success is early recognition and the source control. And if the patient is suspected, not yet confirmed, but patient is undergoing a certain procedure, which are either generating procedure, for example, if somebody is doing bronchoscopy and nasopharyngeal swab, in that case, WHO recommends to use empiric addition precautions, which is more than wearing the face mask, like you have to wear the N95 mask and goggles, head covers, etc. WHO also recommend implementation of the administrative controls, which is quite broad spectrum. It begins with the provision of the adequate training for the healthcare workers. Then they need to be aware of the infection prevention and control practices, and they need to be complied with it. And the WHO also recommends to have optimal patient-to-staff ratio. We should not be overstaffing. We should not be understaffing. In National Guard Hospital, Jeddah, what we have done with we have postponed some elective procedures. We have started virtual and telemedicine clinic, and with the help of that, we were able to reduce the number of patients visiting the hospital by 40 to 50%. And likewise, what we have done at the administration, they have reduced the workforce by 50%. For example, we as a clinical pharmacist, we go to hospital 3-4 days, and then we stay home 3-4 days. Actually, we're not off from the work. We have the remote access. We can see the patient. We can verify the chemotherapy orders. We can see the patient. We can give up a recommendation, but actually we don't go to hospital. So we go to hospital 3-4 days, and then we stay at home 3-4 days. It's like we are on call. So with this approach, we are able to reduce the number of people visiting the hospital and reduce the risk of exposure to COVID-19. And WHO recommends to establish a surveillance process for acute respiratory infections potentially caused by COVID-19 among the healthcare workers. And also it ensures, it recommends to ensure that healthcare workers and the public understand the importance of promptly seeking medical care. WHO also recommends to use environmental and engineering control, and of course, everybody is aware of that. Those who are working in the operation, like maintaining the 6 feet distance or social distancing, that's really important, and try to make sure adequate ventilation in all the areas, and environmental cleaning, which refers to the housekeeping, could be done appropriately. This was the form that I wanted to share with you, which is acute respiratory infection screening form for adults and pediatrics. We have it in our hospital. If a patient comes to our hospital, so we have to fill this form, and it has Part A and Part B, and the Part A is the clinical symptom, and the Part B is the risk of the exposure to MERS or COVID-19. So each parameter has points, and if the score is more than 4, then this patient is more likely to have acute respiratory infection, and we isolate the patient, and we do not discontinue the isolation until the patient is PCR negative for COVID-19. So this was I was referring to, that because this virus, behavior of this virus was known in first week of April, that it can travel some distance and stay in the air. So it was recommended to wear the face mask in the public setting where the social distancing is not possible. There is another myth. I have been contacted many times by many people, like, can we take hydroxychloroquine or chloroquine as a prophylaxis? And I saw this in Twitter and social media. So, well, there is no recommendation to use chloroquine or hydroxychloroquine, and they are not recommended by any international agency, and they have their own untoward effects. I think everybody is aware of the clinical presentation of COVID-19, and incubation period is typically 14 days. From the earlier studies from China, we found like symptoms may appear in 4 to 5 days, and some other studies have shown that symptoms may appear after 10, 11 days. Well, we have seen like most of the patients in our country are asymptomatic patients, and they typically present with cough, fever, fatigue, anorexia, shortness of breath, sputum introduction, and myalgia. But we have seen a couple of patients who had like very vague symptoms. They had no fever, no cough, no other presentation, but they had just the alteration of sense of taste and sense of smell, which is now reported also one of the presentation or symptoms, signs and symptoms of the COVID-19. They had no other symptoms. So when we tested them, they were positive. These are the risk factors for severe illness. Age is single most significant, strongest risk factor for severe illness, as we have learned from the mortality rate in Italy. Italy is very well known for its elderly patient population. And I would go all the way down to cancer. The cancer patients are very vulnerable patients to contract COVID-19, and whenever they contract, they can have the severe events. And then the other risk factors are cardiovascular disease, prior stroke, diabetes, chronic kidney disease, and medications against ACE and ERK. Well, there's a myth about ACE and ERK that they can hypothetically increase the severity of the COVID-19 disease because of the fact that they can increase the expression of angiotensin converting enzyme 2, which is used by COVID-19 as a receptor to enter into the host cells. Well, there have been no data which suggest a link between ACE inhibitor or ERK with the worst COVID-19 outcome. So therefore, American Heart Association and Heart Failure Society of America and American College of Cardiology, they have released their statement clearly recommending continuation of these drugs for the patient already receiving them for heart failure, hypertension, or ischemic heart disease. Although I know many of my friends, they were on either ACE or ERK, so they have shifted themselves to other antihypertensive medication. The same is the story with the NSAIDs. Now let's move to the topic of our webinar, which is COVID-19 and cancer. From the early studies from China, we found that the mortality rates in cancer patients when they contracted the COVID-19 was nearly 6%. There was another study published in JAMA which showed that those patients who had cancer and when they contracted COVID-19, they had more severe events such as admission to ICU and they required ventilation, and more people actually died. There was another study published in Lancet Oncology which actually compared two groups of patients, those COVID-19 patients, those who had no cancer versus the patient those who had cancer, and they included among the cancer patients those who had active cancer and those who were the cancer survivors. And you can see there's a clear spread of the curve. So those patients who had cancer, including active cancer and the cancer survivors, they had higher probability of the severe events, which is ICU admission, requirement of ventilator support, and the death, versus those patients who were not cancer. So that tells you that the cancer is significant predictor for severe events of the COVID-19 disease. So why patients are a risk factor for severe COVID-19 disease? Because of these risk factors. Most cancer patients, they are immunosuppressed after receiving chemotherapy, they're neutropenic, they're lymphopenic, and transplant patients, those who are taking graft versus host disease prophylaxis, treatment, or steroids, they will be immunosuppressed. Most of the patients have advanced age, poor performance status, and have organ dysfunction, and many of them, they have comorbidities. So these are the risk factors which make the cancer patient vulnerable to contract severe COVID-19 disease. Now let's move to the management of cancer during the COVID-19 pandemic crisis. One of the most important things which most of the international oncology societies have emphasized on is to have a multidisciplinary approach and to have an open dialogue between healthcare providers and the patients. But one of the most important things that we really need to do or really need to exercise is to see the risk of delaying chemotherapy versus the harm of COVID-19 infection. So we need to really balance this risk and evaluate whether if we delay chemotherapy, is it more risky than patient contract COVID-19, the harm of contract COVID-19 is more than the risk of delaying chemotherapy. So this is up to the oncology physicians, and we can also participate collaboratively with the physician in order to calculate this risk. So we'll talk about that when we come to the recommendation from the platform of the SOPA. We'll discuss these in details. But whatever decision that we make, we are delaying chemotherapy because we are concerned about the harm of COVID-19. We have to discuss these plans very well with the patient and caregivers, and we have to be very fair and transparent in making decisions. As I said earlier, that because of this pandemic crisis of COVID-19, so international oncology societies, NCCN, ASCO, their experts, they have published their guidance, insight, and advices. How can we provide the optimal care to cancer patients in this COVID-19 pandemic crisis? I would not say optimal care, because optimal care refers to the traditional oncology care, which is the pre-pandemic oncology care. That's not possible, and I'm not optimistic that we're gonna go back to traditional oncology care anywhere before 6 months. Maybe it will take more. So our new normal is what we are going through right now, and we need to really establish our new normal for our country and platform oncology assembly and because normal for to provide the best possible oncology care to cancer patients. I really like the approach of COVID-19, the sources from NCCN guidelines. NCCN guidelines, they provide you a series of recorded webinars under American Cancer Society COVID-19 and Cancer Eco Series. And there are some live webinars. I have attended one of them. I have attended these recorded webinars. These are very helpful. The last one was May 5. And they also have recorded webinars for caregivers. And they also have some courses, which is free. It does not require any fee for that. And the courses will make you able to you will be able to learn how to talk to patients about cancer treatment, risk factors in treatment, cessation during the COVID-19 pandemic. The other thing that I like guideline is that they have provided site-specific cancer recommendation, treatment of cancer recommendation, site-specific cancer treatment recommendation, and these are the cancer that we have the site-specific recommendation from the NCCN guidelines. We have the recommendation for breast cancer, colorectal cancer, melanoma, non-melanoma, non-small cell lung cancer, prostate cancer, and there are recommendations for T-cell and primary cutaneous lymphomas as well. I'll take an example of breast cancer. So NCCN has recommendation for prioritization of the treatment and trial of the breast cancer patient during the COVID-19 pandemic crisis. So they have categorized patients into 3 categories, the category A, B, and C. Category A includes those patients who are in life-threatening situation, they are clinically unstable and completely intolerable. And in this patient population, we cannot delay cancer therapy in COVID-19 pandemic crisis. So these are our priority, and these patients should be treated as soon as possible, and their treatment should not be delayed. Then there is category B. NCCN believes that the most of the patients fall into this category. So these are the patients who do not have immediately life-threatening condition, and we can defer or delay chemotherapy for some time, for example, for 2 months, 3 months. It cannot be indefinitely delayed until the end of the pandemic. And then we have the C category. These are the patients who are stable patients. For example, those patients like early breast cancer. I'm not talking about triple negative breast cancer or positive breast cancer. For example, look at early stage breast cancer with no lymph node positive disease, and they have pathological complete response after the end of chemotherapy and after the surgery. There is no residual disease. So these are the patients. Probably we can wait until the pandemic is over, and that would not adversely affect the outcome if we give them chemotherapy. Similarly, guidelines, they provide a lot of information and guidance, and these recommendations should be used as guidance for prioritizing various aspects of cancer care in order to mitigate the negative effects of COVID-19 pandemic on management of cancer patients. Now, move to our specialty, which is pharmaceutical services during the COVID-19 pandemic crisis. I think everybody knows that pharmacists are the frontline soldiers. They are fighting against the COVID-19 on the borders because they are the most accessible healthcare providers. And even in the New York City, the governor of New York has authorized the pharmacists to even test the COVID-19 patients. So therefore, we should understand the epidemiology of COVID-19 and the best and appropriate infection prevention and control practices. And we have this ASHP COVID-19 resource center is there. We can get a lot of information from there. And actually, there's a lot of myth and misinformation about COVID-19 surrounding around the globe among the people. And we as a pharmacist, as we are readily accessible to the public, so we can develop healthy beliefs among the customers or patients. We can develop healthy behaviors among the patients and educate them to adopt the best infection prevention control practices. And we can tell them to stay home, stay safe, and by this we can mitigate the negative impact of COVID-19. So when we talk about pharmaceutical services to cancer patient, we have 3 different roles. We have clinical role, the role of the clinical pharmacist, and we have operational role, which is the distribution of drugs, and we have the administrative role. So we'll talk about them one by one. So first, let's talk about oncology clinical pharmacist role in COVID-19 pandemic crisis. We know the job description or the role of the clinical pharmacist in oncology and traditional oncology care are the same. Actually, this role is even more pronounced and obvious in this pandemic, that we attend around with the multidisciplinary team. We involved in the direct patient care. We provide patient education, and we provide our recommendation to the medical team, and we help in clinical decision making. And actually, we work as a bridge between the oncology physician and the operational pharmacy for a number of reasons. And because of this pandemic crisis, we are working very collaboratively with oncology physicians physician to develop alternative treatment plans and strategies to reduce the patient-resistant oncology centers during the COVID-19 break. Not only this, we also have some critical shortage of oncology medications in the country because of travel ban restrictions on custom import and export restrictions. So we have a lot of issues with the shortage of medications. So we have to think about alternative strategies. For that reason, we are working very collaboratively with the oncology physician, and we're working, acting as a bridge between the oncology physician and the operating pharmacy. So I would like to here appreciate Dr. Majid and the organizers, the experts of the SOPA. There were around 12 experts of SOPA who came up with this idea to list the practical strategies in order to reduce the cancer patients' visit to oncology center during the COVID-19 pandemic, as the cancer patients are most vulnerable patient to contract severe COVID-19 disease. And I would really like to appreciate all those experts who participated in writing this paper. This paper is ready, and it will be submitted to one of the peer-reviewed journals very soon, and it will be published, and that will be a great guidance not only for this country but also for the whole region, inshallah. So we had 8 recommendations in this paper, and the first recommendation is about delaying adjuvant chemotherapy within the recommended range of treatment initiation. There's no doubt about the usefulness of the adjuvant chemotherapy. It reduces the disease progression and improves the overall survival. Well, there's still a debate about timing of starting adjuvant chemotherapy. So from the platform of the SOPA, we have recommended delaying adjuvant chemotherapy for a maximum of 12 weeks in early stage breast cancer, of course excluding triple negative breast cancer that had positive breast cancer, as they have the prognosis, and delaying adjuvant chemotherapy in these patients had the detrimental effects. And for colorectal and gastric cancer patients, the adjuvant chemotherapy should not be delayed more than 2 weeks, 2 months. The second recommendation from our SOPA platform was to extend the dosing schedule of cancer therapy. There are a lot of examples that we have listed in our paper, but I'm discussing only a few of them because of paucity of time. We know immune checkpoint inhibitors like nivolumab and pembrolizumab are used quite commonly in many indications in cancer patients. So receive immune checkpoint inhibitors. So we thought about extending the schedule of 40 milligram every 2 weeks, and pembrolizumab 200 milligram every 3 weeks. So the others, Union as well as US FDA, nivolumab to be used at 480 milligram every 4 weeks, and pembrolizumab as 400 milligram every 6 weeks. So we recommended switching all patients on monotherapy nivolumab and pembrolizumab to 480 milligram every 4 weeks and 400 milligram every 6 weeks, respectively. Other examples are taxanes. As we have seen in our clinical practice, most of the physicians, they use docetaxel and paclitaxel weekly. Use of paclitaxel weekly had an improved overall survival, whereas the overall the Q3 weekly. But because of the benefit and the overall survival in weekly paclitaxel, many people are using actually weekly paclitaxel. Although there was no difference in docetaxel Q3 weekly versus weekly. However, from the platform of the SOPA, we are recommending to use taxanes Q3 weekly in order to minimize the risk of the visits of the cancer patient within the oncology center. The bone modifying agent for the bone metastasis, there was one CALGB trial which compared zoledronic acid 4 milligram every 28 days versus every 12 weeks. There was no difference in terms of physical related events. So from the SOPA assembly, we have recommended to use zoledronic acid every 12 weeks instead of every 4 weeks. Some patients can be switched from zoledronic acid to denosumab, and denosumab can also be used every 12 weeks. Then we have LHRH analogs like leuprolide, triptorelin, that are approved as once monthly, or once every 20 days, or once every 3 months, and once every 6 months. So we are recommending to use LHRH analog every 12 weeks, or even every 6 months for breast and prostate cancer. Although this recommendation is mainly for prostate cancer, but because of this pandemic, we're also recommending this for breast cancer. Our recommendation is to switch from intravenous chemotherapy oral or subcutaneous route of administration, and there is great guidance from candidates from IV therapy to chemotherapy. There's some downsides of switching to oral chemotherapy. Oral chemotherapy is the compliance of these patients, especially patients who have on oral polypharmacy, but with our education and reassurance, we can try to mitigate this. And oral chemotherapy is definitely going to reduce their number of visits to the center. So, for example, like oral but when you use it on the side, you have to availability is 50%. Capecitabine can be used in 5 fluorates, and there are many other examples like cyclophosphamide. The part B of the recommendation 3 is switching from intravenous chemotherapy to subcutaneous route of administration. The great examples which saves infusions and a lot of time is rituximab subcutaneous, which saves infusions and a lot of time, and daratumumab subcutaneous have recently been approved by US FDA, and other options, the trastuzumab subcutaneous use of trastuzumab save infusions and a lot of time, and even the ASCO, and I'll talk about another recommendation is medication can be even administered at home if they had no allergy before. So recommendation number 4 is about home administration of chemotherapy and supportive care therapy. It's not something new, and there are a couple of studies that I came across. One of the studies was published in Journal of Pediatric Oncology Nursing 2 years ago, where actually more than 100 parents included in the questionnaire. So they were given training to administer chemotherapy. Initially, these parents were nervous about administration of chemotherapy at home, but later on they were more satisfied. They had less financial burden, and they had less disturbance of their family and the children, and they liked it. Actually, they appreciated that. And send the nurses to home and administer this chemotherapy. And ASCO is encouraging, American Society of Oncology is encouraging to do home administration of therapy when it is feasible. A lot of examples, for example, as a scientist, push chemotherapy, like vincristine, and some other medication which can be given to, for example, and even people about trastuzumab or subcutaneous rituximab to be administered at home with specialized nurses visiting the cancer patients' home. I think supportive care is pretty easy to be given at home. We can encourage the patient to take the hydration orally, and we recommend to give antibiotics orally instead of IV. Growth factor can be taken by patient themselves. And sometimes we have febrile neutropenic patients admitted on the floor who have recovered from the neutropenia. They had bacteremia susceptible to antibiotics or even ESBL. So we can give them once daily or twice daily antibiotics, and that can be administered at home. And we had already started this practice before the pandemic, and that can be very helpful actually in this current pandemic situation. For example, if somebody has E. coli susceptible to ceftriaxone, so giving ceftriaxone 2 grams once daily at home is very feasible. Or if somebody has ESBL, and venom 1 gram once daily is pretty feasible in the home setting, and we have been doing it even before the pandemic era. We have recommendation number 5, which is to delay the stem cell transplant if medically feasible. That's possible in allogenic stem cell transplant patients. Those patients who have, for example, MRD negative disease, ALL patients, and those patients, AML patients, for example, intermediate risk AML patients, or sickle cell myelofibrosis patients who are tolerating the transfusion, we can delay their transplant because once they get transplant, they're immunocompromised, they can contract this COVID-19, and the harm of the COVID-19 will be much more devastating. And in autologous stem cell transplant, multiple myeloma patients who have very good partial response or complete response, stringent complete response, these are the patients who can actually wait are Hodgkin disease patients who have metabolic complete response after receiving salvage chemotherapy. Particularly these days, we are using brentuximab vedotin and immune checkpoint inhibitors, and many patients actually go into a metabolic complete response after doing the PET scan. So those are the patients who can wait actually until this pandemic is over. Recommendation number 6 is the activation of the telemedicine. I think this is the hot subject. Everybody around the globe, they have started somehow the telemedicine in their countries, and the same thing here in our hospital and in the country. Many people, they have already started the telemedicine, but that needs really a multidisciplinary team of trained personals. During this COVID-19 pandemic crisis, it is considered as an essential step to reduce the frequency of visits and possible exposure to the virus. And one of the things that we have done from the platform of the Pharmaceutical Care Service, for example, we have anticoagulation clinic, pharmacists run anticoagulation clinic. We started virtual clinic like a couple of months ago, and we were able to reduce the number of patients visiting the hospital. And this virtual clinic can be activated or can be started for stable patients, with those who are on oral chemotherapy, for CML, lung cancer, breast cancer, renal cancer, and prostate cancer. And then we have the recommendation number 7, which is to consider intermittent chemotherapy of or treatment discontinuation for eligible patients. I think this is a great approach. Even before the pandemic era, some people have been doing using intermittent chemotherapy in colorectal cancer, breast cancer, and we can do the same in the pandemic situation. And some patients, those who are in deep molecular response, for example, CML patient, chronic myeloid leukemia patient who have deep molecular response for more than 2 years, we can offer them treatment-free remission. And actually, one of my resident, PGY2 resident, Dr. Afnan, she have done this study under our supervision, and we have reported the outcome of TFR of more than 90%. 6 months TFR was more than 90%, which is the highest ever TFR reported ever in the world. And those people who have TFR of 6 months, they tend to continue this treatment-free remission beyond 6 months, and our 1-year TFR is almost similar. 90%. So we can take the consent of the patients and give them treatment-free remission. I mean, this is a great hope, regardless of this pandemic. I mean, this will help more in the pandemic situation, but regardless of the pandemic, we should continue offering them TFR, CML patient who have deep molecular response. And we have recommendation number 8, which is the operational pharmaceutical services. That's about applying innovative ideas to minimize the patient visits to pharmacy. And one way is to send the medication by postal care to the patient houses and use of drive-through services that will minimize the risk of exposure of patients as well as the pharmacy personnel to COVID-19. And one of the things that we have done and people are doing is using the postal carriers, for example, SAMHSA. There are some little caveats to these postal carriers, that they do not have in their default contracts to include the cold chain, supplier, cold chain, transport. So you have to sign a new agreement or new contracts with them, which will include the cold chain transport or cold chain storage. Because if you are sending subcutaneous medication or medication which requires the temperature control, so then this needs to have the contract of the cold chain storage. Other thing is to supply more medication to chronic and stable patients, but you have to make sure that you maintain the pharmacy stack, and which is becoming a problem right now in this current pandemic because of the travel restriction and customs and other bans. Other thing is to have collaboration between pharmacy departments and oncology centers. And actually, there should be collaboration not only between the pharmacy department, there should be collaboration between the oncology centers in the country. And one of the example I would like to quote here, one of the patients from Medina, Dr. Salam Abdali, who is our panelist today here, King Fahd Hospital, Medina. There was here is a leukemia patient, and they contacted with me that they need cladribine. And then I discussed with our nutrition and oncology center. The patient was actually coming to our hospital to get the treatment here. So I talked to Dr. Salman, and I asked him, okay, you can keep this patient there, and we can send you medication there, and you can get the patient treated there, because there was travel restrictions to travel from Medina to Jeddah as well. The other thing is to have an activation of 24 hours hotline. That's really important. Our on-call service with clinical oncology pharmacists for consultation and communication regarding the use of medications at home setting. We have the multidisciplinary management guideline for COVID-19 at King Abdulaziz Medical City, in our hospital, which is a broad spectrum guideline. It not only talks about prevention and control of the infection, but also talks about the management of the COVID-19, and also talks about the how can we deliver the adult and pediatric hematology cancer care and other specialties. But I'm not going to talk about that. I'm just going to talk about the proper use of the PPE. So we have mentioned in our guidelines that those patients who are suspected to have COVID-19, we need to, the difference between the suspected and the confirmed is that you can wear the surgical mask for the patient who is suspected to have COVID-19, but you have to wear the N95 mask for a patient who is confirmed with COVID-19, unless you're doing some aerosol generating procedures where you have to have empiric precautions as per WHO to wear the N95 mask and disposable gloves and the hard covers. So how do we clear the patient if he's suspected and confirmed case? How do we clear from the isolation? So it's isolation, the discontinuation of the isolation is done by the infection prevention and control. The patient who is suspected, he should have a negative COVID-19. And the patient who is confirmed COVID-19, we do every 5 days, COVID-19 PCR. And we need to have 2 negative PCR, and then MRP, man responsible physician or his designee, has to document this in the health information system, a note of discontinuation of isolation. Then the infection prevention control can discontinue the isolation, and after that, patient has to stay. After the discharge, patient has to continue the 14 days of home isolation. Some administrative guidelines. So CDC COVID-19 guidelines recommends and advise the staff who are sick to stay home. And for that, the administrators should have flexible sick leave policies, which should not be good and should be consistent with public health guidance. One slide about the filling prescription. The CDC COVID-19 guidelines, they believe that actual process of preparing medication or dispensing is not a direct patient care activity. There are a lot of components of medication dispensing. It involves receiving prescription from the patient. It could be paper prescription, patient counseling, patient education. That may expose the pharmacy personnel to individuals who may have respiratory illness. So for that reason, they need to have, wear the PPE. They need to have the same infection prevention and control practices. And in addition to that, workplace guidance, pharmacy staff should provide the hand sanitizer on counters for use by customers and have sufficient and easy access to soap and water or hand sanitizer for staff. And CDC recommends, I'm reading word by word because it's the CDC guidelines, so they encourage all prescribers to submit prescription orders via telephone or electronically. The paper prescription should be required. I think in the country, most of the hospitals, they have CPOE and online prescribing. So pharmacies should develop procedures to avoid handling paper prescription in accordance with appropriate state laws, regulation, or executive orders. Lastly, I would like to show you the checklist of ASHP. I'm now going to go into the details of that. I will mention only 2 points. The first one is all personnel in clinical settings should wear a face mask when within 6 feet of another person or in a public space, regardless that other person is symptomatic or not. The other thing I would like to focus on is to have virtual meeting, not face-to-face meeting. For example, I'm attending Oncology-Hematology rounds, I'm attending tumor board meeting, I'm attending pharmacy and therapeutic meeting. So we're doing all these meetings virtually, not face-to-face meeting. That would reduce the risk of exposure of us to COVID-19. Lastly, we need to have a list of essential medication for the country and for the institution. And WHO published essential medication list first week of April last year in their meeting held in Geneva. It's a very comprehensive list. 65-page document. So I was contacted by American College and Ministry of National Health Affairs, Jeddah, because Saudi FDA contacted with him to provide a list of essential medication, list of essential oncology medication from the perspective of the Ministry of National Guard Health Affairs. I think Saudi FDA contacted with other hospitals, yes, King Faisal, Ministry of Health, Security Forces, Ministry of National Guard Health Affairs to take a feedback of list of the essential oncology medication. So I submitted the list of the essential medication to our oncology department to Saudi FDA. This list includes and this is essential medications for Ministry of National Guard Health Affairs in the traditional oncology care even before the pandemic. And Saudi FDA is also looking towards to have a list of medication which we have critical stock issues, those medication which we have supply issues, as we have critical stock issues. So they would like to communicate with the manufacturers to ask them about extending the expiry beyond use. And we have provided a list of 40 medications, which is not only oncology, but also non-oncology medications as well. And they have contacted with other hospitals as well for the same reason. So in conclusion, cancer management is a significant concern during COVID-19 pandemic in all healthcare settings, as our cancer patients are vulnerable to contract severe COVID-19 disease. As the International Oncology Societies have emphasized, the multidisciplinary approach should be activated with open communication between the healthcare providers and patients. And oncology pharmacists should have an active role in maintaining access to cancer therapy and minimize the risk of exposure to COVID-19. And innovative ways and alternative treatment plans should be implemented to combat COVID-19. And we have to be a frontline soldier in this war against the COVID-19 to not only save our cancer patients, but also to save ourselves and our families. With that, I would like to thank for your attention. Thank you so much.
Thank you so much, Dr. Khan, for this amazing presentation. It was very much helpful, and we got some questions here for you from the audiences, if you don't mind. So I have the first question here from Samah, is asking about what's been done internationally for cancer patients who are admitted with fever through the ER. Currently in their institution is isolating them as if they have COVID until they have negative results. Are they at higher risk? So they've been placed in COVID areas. So I think that's the question. So what are you doing when you have a patient who have fever and comes to the ER?
So as I mentioned, WHO is recommending triage and early identification, and we have our guidelines, and we are following. We have our actually scoring system, which is acute respiratory infection scoring system. It has two parameters. One is the symptom, the other one is the risk of exposure. So if the patient has fever and has the symptoms, we definitely are going to isolate this patient. We consider this patient is suspected, and there is a WHO guidance. I began my talk with how to take care of patients when suspected COVID-19 patient arrive in the hospital. So what the patient isolation until the COVID-19 PCR is negative.
Perfect. Thank you for your answer. And I think we are also doing the same exactly in other hospitals too. So there's another question here by Dr. Muhammad Omar Khalid. He's asking about he's asking about the extended dosing schedule that was approved or supported by insurance or payers. So this is his question. And then second question, please share your experience in terms of any clinical challenges in extended dosing schedule.
So what was the coverage, insurance coverage?
I think he's asking, is it approved and is it covered?
Yeah, so there is in our recommendation, which is going to be published very soon from the platform of the SOPA. So whatever recommendation we have put in our paper, I included in my presentation. This is not only my recommendation, this is a recommendation of our SOPA, and it is evidence-based. For example, nivolumab 480 milligram is approved by European Union and it's approved by US FDA. Pembrolizumab, for example, 400 milligram every 6 weeks, it's approved by EMEA and it's approved by US FDA. And paclitaxel and docetaxel docetaxel, these are approved weekly and these are approved every 3 weeks. And leuprolide, triptorelin, these are approved once monthly and these are approved every 3 months and these are approved every 6 months. So whatever recommendation which is coming from the platform of the SOPA is all evidence-based and it is backed by international approvals from one of the agencies. So all of them, these are evidence-based. So there should be no issue of insurance coverage or funding from any source.
So we have another question here in the same topic from Dr. Yusuf Al-Ola, and he's asking about the extending, that he's worried about extending immunotherapy using higher doses that might lead to more adverse events compared to the traditional dosing. So it will lead eventually to more ER visits and then also more risk of COVID-19 exposure. So we should be very cautious. That's what he's saying in using extended dosing. I don't know if you have any comments regarding that.
Most of the actually, I'm not sure about the. I think it's very safe. It's approved by EMA. It's approved by US FDA based on the pharmacokinetic studies. So as long as the pharmacokinetic studies and pharmacodynamic studies have proven these are compatible schedule, I'm not that much worried about side effects. However, it has to be tested in randomized control trial fashion to compare these two practices. With regards to the safety, but pharmacokinetically and pharmacodynamically, these were compatible.
Okay, cool. So the next question, Dr. Awsi Shamsan is asking about COVID-19 vaccine. So if it's going to get approved soon, will you recommend it to cancer patients? And which vaccine type, live attenuated killed viral vector mRNA, you expect will be more hazardous for cancer patients?
Well, the vaccine, it's too early to say anything about vaccine right now. I think the vaccine has been made and it's started in phase 1 clinical trial in US. There are 2 companies which have been registered in US. I think it's going to take at least 12 months to 18 months. Well, of course, I think it's not only cancer patients, all patients on earth are going to be vaccinated. They're going to be penalty if somebody is not vaccinated. He will have travel bans. Even the job, the organization, they will require people to have this vaccination because it's really a devastating disease. And the only way that we can eradicate this disease is the vaccination. Whatever treatment that we are doing right now, we know it's not working. So the only way we can eradicate the disease is the vaccination. So is the cancer patient. So for example, our even post-transplant patients, we give them vaccination. So, I mean, we have to give the vaccination. So whatever vaccine is available, which is approved by international authorities, international regulatory agencies, will be given to the cancer patients as well.
I think additionally, just want to add that definitely before starting chemotherapy, it's hard to give it once the patient is immunocompromised at that stat. So prior to, let's say, chemotherapy or any procedure, or after we're done